Good morning, everybody, and thank you for joining this morning. This is as David said, this is a series of webinars. This first one is really the introductory and an overview of the strategic commissioning support. Further webinars will go into a bit more detail on some of the specific technicalities around it, but we'll come to that at the end. So since this is the first of our webinars, I thought a quick introduction to Healthcare Improvement Scotland. In the new integrated space, the national organisations that used to work differently in health and in social care are now working much more closely together, and so we're delighted to be doing this in conjunction with Improvement Scotland. Healthcare Improvement Scotland traditionally supported the NHS and now supports the NHS and the health and social care partnerships, and is made up of 4 key areas. One is the Evidence Directorate, which people may be familiar with. This, the Scottish Medicines Consortium gives guidance on medicine and standards. The Improvement Hub, for which we are part, offering tailored and improvement support to the partnerships. The Scottish Health Council, which works around areas of community engagement, and our Quality Insurance, which inspects NHS programmes of work and is part of the joint insurance along with the Care Inspectorate for the new health and social care partnerships. So the iHub is the coming together of what was the joint improvement team, the Quest, which was the Scottish Government Quality and Efficiency Support Team, and Healthcare Improvement Scotland's QI Hub. So this brings together all that expertise. The work that we're doing comes in 3 parts. One is the plan programme. Some people may be familiar with the work of the Scottish Patient Safety Programme and other work such as the Effective Care Pathway and Living Well in Communities. We've also developed a responsive support, which is the Tailored and Responsive Support Team, and this is in recognition that the direction of travel within health and social care now is that the support and the direction of travel is really coming from the localities up rather than the Scottish Government giving direction down. And this unit responds to understanding what people's needs are and concerns and puts in the tailored response through our improvement associates in order to be able to help with that. And the last part is grants and allocations, and we recently just closed the first round of the Improvement Fund work, which had a significantly large amount of applications, and we'll be looking to continue that work. So the Strategic Commissioning Support Unit is part of, it's in that interim area between the plan programmes and the responsive support, where we're looking very much to hear from partnerships what their challenges are about developing their strategic commissioning plans and implementing the shift in the balance of care. To do that, we very much recognise that this is done in a Scottish context. In England, commissioning support units have grown up to support the partnerships and the health and social and the health boards down there, but they're very much based on a competitive tender model and a tariff-based model. In Scotland, we have a real opportunity to deliver our strategic commissioning in a way that's person-centred, recognises that the localities are where the needs of the people can be best understood, that it's about collaboration between national organisations, local organisations, between the third and independent sector and the statutory bodies. And that collaboration brings around greater innovation and efficiencies in our system. We want to make sure, and the joy of working in an organisation with the Evidence Directorate is that we can pull on the areas of good practice not only in Scotland but from around the world and be able to interpret and share that. We're working very much with Health Scotland to make sure the entire pouch is a human rights-based approach, very much focused on the needs and rights of people, and the needs and rights of people to have a choice and a decision in the health and social care services that they receive. In Northern Ireland, they had an expression called shifting left, which was a recognition that the care had been far too long, far too focused on the acute, and that actually moving down through primary care into community support and recognising the value of early intervention and prevention means that services can be delivered closer to people where they want them, but also we can reduce, and I know it's a terrible expression, but reduce the demand failure in our system, which is taking up too much of our resource, and instead focus that on supporting people in their communities. And lastly, we're very clear that the national care standards, which are in consultation, which should conclude this week, that the implementation of the national care standards will very much tie in with the strategic commissioning approach that we're proposing in Scotland, and all the modelling and evidence that we develop will have recognition to support the partnerships and be able to meet those standards. But let's not be naive. We all recognise the really difficult financial times that we're facing, and the delivery plan that was published in December very much puts the pressure on the health and social care partnerships to do an almost unprecedented level of shifting that balance of care. It talks about reducing 400,000 bed days in the system, a 10% reduction to unscheduled care bed days. That the need is to reduce the pressure on the primary and community care services, and about how workforce is developed within those settings. And for the first time puts a really, really clear pressure on the system to shift the spend back to the NHS frontline and into primary and community-based services.
Thank you very much. I'm Thomas Dodd. I'm going to move now to describe an overview of strategic commissioning, picking up on Diana's comments about the personal and policy context of that activity. I think it's pretty clear from Diana's comments that we can understand why the process of commissioning effective services is urgent and important, but we need to consider some various components of the process itself. To begin with a definition, strategic commissioning is the process of understanding, planning and delivering better health and social care outcomes. And we recognise that a substantial amount of work can be needed to deliver this process effectively and efficiently. The systems we work within are extensive and complex, and we need to take care to understand the impact of our actions and potential actions on those systems. Strategic commissioning, as you probably will gather, is embodied in legislation and in public policy. Some of those policy outcomes which Diana described just now, and in fact in some services good processes of strategic commissioning have been embedded for several years. At this stage, it's worth pointing out we use the term strategic commissioning to differ slightly from the day-to-day commissioning, which we regard as relating mainly to the process of care planning for a particular individual. Both are important, but they exist in slightly different contexts. The process of strategic commissioning, when well planned, offers the opportunity to increase the value and the financial stability and sustainability of care delivery by making the most effective use of the resources that we have available and thinking about how to deliver services which work for the needs of individuals and localities in a way that affects the or ensures rather that the balance of resources spent where it achieves the most. And that often involves, although not exclusively, focusing on prevention and early intervention. If we're going to do that effectively, we need to consider elements of both service capacity and also the flow within and between services. So I think, as is clear, the process of actually going about strategic commissioning can often prove very challenging. And in fact, some recent reviews, some of the work in Scotland as well, have considered some of the pressures and challenges facing local strategic commissioning capacity. And again, as Diana had indicated previously, there's some opportunities to obtain additional support for those processes if they're required. These activities are based around the strategic commissioning cycle of assess, plan, do and review. Before I get into the detail of that, it's worth considering what strategic commissioning is not. It's not about specifically better procurement or obtaining a cheaper source of pencils or paper, so spending the money in the same way. But it asks rather whether we should still be writing letters or whether there are better ways of communicating with individuals. Some of the thoughts on this slide cover then the difference, for example, between establishing a falls response program or perhaps dance classes in care homes to support people's agility, fitness and perhaps result in fewer falls. I guess possibly slightly fatuous examples, but I'm sure that you take the point. The wider context here, of course, is that the approaches that you might choose to take aren't always relevant to Scotland as a whole. but need to consider the needs of particular localities. So as we can see very clearly, the needs of one locality aren't necessarily the same as those of their neighbours, and so it's worth considering how best to approach strategic commissioning on a locality basis so that the needs of the individuals of those localities are met to best effect. Before we start, we need to make ourselves room to manoeuvre, and one of my favourite reports of recent years is this one by Punt and Leadbeater. This is The Art of Exit. It reflects a view of the English system of commissioning, but I think some of the principles that they outline are relevant to the Scottish system. I won't patronise you by reading the slide to you, but I think that the main point really is that the report is arguing that transformational public innovation and effective commissioning requires at its core effective decommissioning. So thinking very carefully and challenging the incumbent service models. Just because we've always done it this way doesn't mean it's the best way of doing things. And thinking about how we shift mindsets in order to invest most effectively in the new approaches that might better meet current and future population needs. So that really, I suppose, is another way of looking at the difference between salami slicing. I think actually it's been a couple of years since I heard or even used that term, largely because the financial pressures that we face now mean that we can't simply cut spend in the way that we used to. But we really need to think rather differently about the way we approach service delivery. So in the context of feeding one's family, is it that we provide less salami, or do we go about thinking how we might construct a meal in a different way? And perhaps some of this is about then growing our own food, thinking about the menus in different ways to ensure that people gain what they need. I guess stretching the analogy somewhat, some of us know about community allotment initiatives that not only provide food but also the opportunities for engagement, social interaction, and wider benefits thereafter. So moving to particularly then the process of commissioning itself, this material from the commissioning cycle, published here on our, actually it's published on our website, the details of which will follow, looks at the process of planning and delivering services and support for people, and follows, I suppose, four broad phases, those of analyse, plan, do and review. And some of you involved in improvement will recognise that they are pretty familiar from a number of improvement planning cycles. The process here is around considering how best to assess the need of individuals and local populations. Having assessed that need, consider how best to set priorities, procure services which will address those priorities and needs, and then manage an ongoing process of monitoring and evaluating outcomes. The fifth element here, which isn't specifically noted in the cycle but is vitally important to success, is to do that in a way that consults and engages with the people who both deliver those services and the people who are likely to receive them. And in this approach, really, I suppose what I'm trying to get across is that strategic commissioning is about planning and delivering services and support for people. We end up using fairly ugly terms like service users and patients, which seem to segment our wider process of care and support into professional silos. And I think some of this needs to be about identifying the needs of individuals and communities and enabling those people to decide what might best address those needs and their future priorities and desired outcomes. So I guess then the links that we need to make here are about ensuring that investment is linked to agreed outcomes and involves that consideration of options, planning the nature, the range and the quality of our future services, and working in partnership to put those in place. And as you'll see from the diagram, very often commissioning is described as a cyclical process. The model here, it's the Institute of Public Care who originated this model, describes in the outer ring, this is the commissioning process which I've just talked through, but makes then the links in the inner circle to the purchasing and contracting capability that we might need to use to make the links between what we want and how do we go about getting it. So to continue this thread, I suppose what we need to do is associate the largely mathematical processes of population needs analysis, understanding demand, and quantifying the requirements for service delivery, alongside those elements of good practice in terms of managing redesign and in stages. So that's linking the individual citation of personal outcomes into then an aggregation of that data to provide an overview of service capacity and, importantly, of service flow. In my mind, it's entirely clear that this is all underpinned by evidence and the opportunity using that evidence to model service activity, finance, workforce capacity requirements, and the process of flow. But that's not done to the exclusion of understanding people's interaction with those services, which, of course, is the reason for being here at all. So we know, I think, from our work previously that social care commissioned alongside healthcare has significant potential to reduce demand and cost. So one of our priorities when going about strategic commissioning needs to be in that engagement in a partnership way, fairly obviously in the Scottish context, but also ensuring that that engagement is carried through to locality level and supporting people who are effectively engaged and consulted to address those various activities on the left-hand side of the diagram at the moment. Despite me kind of going on about it at some length, the argument here is that really it's important to keep things as simple as possible. The irony is not lost, trust me, and to try and remove some of the complexity and maybe some of the add-on schemes or measures that tend to create additional steps in the processes of care. It's very easy to go around a process to say, well, what about if we just did this as well? I guess the link here is to go back to think about that process of decommissioning services which are less effective or less necessary in favour of more efficient and effective replacements. The nice advantage of that as well is that the simple system makes it easy to navigate from, again, the ugly term of a service user's perspective, but also from the perspective of those people who are already within the system. It can tend to make our lives all a lot easier. As I've said, we need to involve patients, service users, or people, in fact, and professionals in considering those options and redesign from the outset. And in general, we find that the approaches that tend to work would tend to involve multiple interventions at various points within the system rather than single all-encompassing projects that attempt to redesign everything from the top down. The good approaches use clinical expertise to manage inappropriate variation. They use engagement with those people using services, and they make use of that expert opinion very early in the care process. Back to this notion of shifting left and skilling people up rather than down at the early and opportune places for preventative activity. And I guess kind of relating that then to the needs of the population, both in clinical and social terms, but also considering then the issues of general frailty as well as diagnosable challenges. I suppose the wider point here that I'm trying to make is that we find ourselves within systems. We have a good understanding of what matters to health and social care partnerships, but we need to ask the question about what the system feels like for those people who are in there using it, receiving services, obtaining support, and having hopefully their outcomes met. So in relation to strategic commissioning specifically, the integrated approach offers, we think, a number of advantages working across health and care partnerships to consider the issues that matter to those partnerships and to consider those issues from an integrated perspective. So that's about understanding the whole of the system and the flow around it, although relating to the point I made previously, perhaps naive to assume that we can do that in one sheet of paper. I note in passing here that whole system means rather different things to different people. I guess the important point here is to manage those elements that you have within your control effectively and consider the handoffs and flow with other areas of the system. I think then the remaining point is about considering and understanding the consequences of decision making within those interconnected systems And relating back to one of Dan's earlier points is around then thinking about the what tends to be called advance, just shifting people from one point of service to another.
In trying to think about strategic commissioning and how the data can be analysed differently, traditional models have looked at pathways of services and particularly focused a lot on the acute system. It's one of the great frustrations that I hear regularly working in the integrated spaces, is that the system views itself all about how to support more effective discharges from the acute rather than understanding it from a community focus. This is one of the pieces of work that we are developing as a way of looking at the system. So this doesn't tell you anything, and no single piece of data or analysis within this complex system would be able to do that. But this particular example is there to identify and show to planners what is actually within their system in different sectors and how things are around within it, how the patient might flow between services, recognising, of course, that it's not a clean linear system as this indicates. But as I said, this is a really planning tool, which when we worked with the planners on doing this, helped them to recognise some of the unintended consequences from moving or decommissioning services, and also identify where some of those challenging areas where there's potentially not enough resource and lack of resources in particular areas were causing greater and more lower quality but more expensive interventions in others. So from this you can clearly see things identified that care away from home in different settings such as residential respite was having a high capacity use of the system, which was then causing a flow into and preventing flow out of the hospital. And that, from a planning point of view, helps understanding where future investment should be concentrated. There's different ways of looking at this and then developing this, so you can also see it from a person's own lens. So the self-directed support implementation plan takes a picture similar to this, but looks at it from the person and what their flow to them looks like. There's also ways of the LIST team within the partnerships can look at data like this and overlay it with finance and activity to help understand where the particular demands on the system are. Work around high resource individuals that all the partnerships have access to as well through their LIST team and between the LIST team and the iHub is a way of identifying those for whom the spend in their last year of life was particularly high compared to an average spend, and to look at those not in any way to say that spend was inappropriate per se, but to see within that analysis whether it was able to identify whether interventions could have been put in place earlier that would have supported keeping the person at home, keeping them in the community. For example, such work showed in some areas that people, elderly, frail people, were having significant falls in the community, and the lack of advanced care planning meant that that was an ambulance into hospital, for which there was a long and unnecessary stay and complex discharge planning, where we recognise that the balance of risk that an acute hospital might have on a person on discharge could be different from the community teams who were previously supporting the person at home. That work then enables the focus and the attention of energy to make those service changes by highlighting the potential cash releasing benefits that can be made from putting those services in. And these really are the drivers we have in the system at the minute. We know that we want to improve quality of care, but we know that our money is tight. And so we're looking at work and analysing work in this way enables the identification of where people can have better quality, more community and more prevention, but actually will also then release resources within the system, are the win-win that we're trying to achieve. Further work is now being done around the GP clusters, and particularly for those in partnerships where the clusters and locality planning will be coterminous with each other. There's greater work to be done around the data that's available to the GPs in understanding why they're admitting patients to hospital, why they're making particular choices, either because within new models of care and new evidence, better ways to support patients can be done, but equally, if it's about a lack of resource within the community, greater spend in areas of social care, community support could actually change referral pathways from the point of view of the GP, and being able to really see that data clearly and obviously for planners will make a huge amount of difference. We're also clear that traditionally in health and social care, that from the health side, a financial modelling of quality improvement has not been a particular area of focus. And I know those who work in social care, that will have been a great frustration, where the social care side of it has always had to have a much keener eye on the pound. So now that financial modelling can be taken, and with the data, where data sets are now being joined up between the social care data sets and the health data sets, we can do whole system financial modelling and really begin to understand what shifting that balance of care to the front line as indicated and desired in the delivery plan might do. What we're also able to do is begin to look at a greater deal of evidence that talks about this transformational change. These are just some of the reports that create that evidence base. We all know that that in order to change planning, business cases need to be written, and these business cases need to show the evidence of where things have been done before. Some of this change will require brave decisions, and being able to work with clinicians, community, other professionals in the community and in the care system. Having an evidence base that shows that it can be done can create the confidence to make some of those bold decisions. So what we're able to do through our evidence directorate and within the iHub is to begin to thematically look at some of this evidence base to bring out some common themes. We absolutely recognise within this that there is now, because this worked in the northeast of England, it can work in North Lanarkshire. But a lot of the learning from it and the modelling that was done and some of the new ideas and innovations are transferable with local adaptations, and being able to quickly draw on this evidence can help accelerate this need that we have to make this transformational change. So what we want to do is focus our future webinars on these three areas to look at some more of these data tools in more detail, the tools and modelling that are available, to bring some examples of what the LIST team and the acute hospitals are able to see and benchmark themselves against. So in that health and social care planning space, where the responsibility of the devolved care services, also in acute services within the acute, being able to understand what data is available to help do that, I think will be quite important in shifting that balance. So we'll bring some of those tools. There's work being done and developing around greater co-producing services and market facilitation. There's, I know that the Scottish Government is doing work with each of the partnerships right now in looking at their market facilitation plans. So we want to be able to bring some good practice around these areas for sharing. And then lastly, about how to develop those compelling business cases for the change to happen. All the information we've shared with you today is available on our iHub website, including links to some of those publications that we talked about and some of the data modelling. So we'll now open that up to questions.